the third and final day of the 2022 virtual HBUT mini summit. Today's theme, today's theme is adjusting beyond a pandemic focus. This is not to say that that the pandemic's over and that we're moving from it, but it's about how we're going to go and live with kind of an endemic environment where we need to have considerations for COVID, but still how we're going to continue to do the important infectious disease prevention and treatment work that we do on the ground. Give me just one moment to be able to see everyone. Hello there. So for those of you who have been with us the last 2 days, please bear with me as I repeat myself just a little bit. For those of you who are new, we're using Zoom Meeting as our platform. As such, we ask that everyone put their name in their video box. We're going to keep people muted throughout the summit, but please use the chat boxes. So if you have questions for our panelists or our presenters, throw them in there, and our moderators will make sure to pull those in and ask our presenters and presenters and panelists those questions. Additionally, should you have any sort of tech issues or anything else that just needs someone to reach out to, look for the individuals that say "Ask Me" in front of their names. They've been helping us throughout the summit and just making sure folks are connected to the pieces they need. So, and part of what we've done to try to cut down on potential technical issues is have many of the presentations you'll see today pre-recorded, but we'll have the speakers who did those presentations on hand live for Q&A. Additionally, in order to keep this summit as beneficial as possible, we ask that you please fill out the evaluation and list just give us your honest feedback. You can give it anonymously, but it really does help us plan for future summits, whether that's in person or virtual, because the information we're presenting can be done in both sort of environments, and it really helps us though to know if it's the right information that you all want to hear from. Additionally, I want to say thank you to all of our summit planning committee. We've been talking about the steering committee the last couple of days, but I'd be remiss if I didn't also thank our planning committee, which includes many of the same folks as our steering committee, but others as well, to really give a broad perspective. Additionally, over the last week, we'd asked attendees to send us songs as part of the Sounds of the Summit. Thank you for everyone who's participated. We'll have some more songs over our breaks today. And then as part of our conference wrap-up email that we'll send out with links to recordings and slides and other things, I will also leave the link to that playlist for any of those of you who found a song you like and want to listen to it again moving forward. But to kick off today's session, we actually have Dr. Carolyn Wester, who is the Director of the Division of Viral Hepatitis at the National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention within the CDC. That's a mouthful, but she's the viral hepatitis counterpart to Dr. LeBou, who we heard from yesterday. Prior to this role, which she was installed in December 2018, so almost happy 4-year anniversary, Dr. Wester. She spent 10 years as the medical director for HIV, STDs, and viral hepatitis at the Tennessee Department of Health. And prior to that, she was a research associate at the Harvard T.H. Chan School of Public Health and the director of urogynecology and pelvic reconstructive surgery section at the Cook County Hospital in Chicago, my home state of Illinois. She has her MD from Dartmouth's Geisel School of Medicine and her MPH from Harvard's T.H. Chan School of Public Health. So without further ado, I will turn it over to Dr. Wester.
Welcome, and thank you to...
One second. There we go.
Hep B United and the TB Elimination Alliance for hosting this mini summit and for your continued work to reach Asian American, Native Hawaiian, and Pacific Islander communities with education and awareness on hepatitis B and TB. I'm delighted to have this opportunity to speak today about how CDC is addressing hepatitis B, the hepatitis B trends from our data, and our current work and future priorities to address persistent hepatitis B disparities. Next. Since last year's summit, CDC's viral hepatitis program has worked to release additional recommendations to prevent hepatitis B infections and related morbidity and mortality. In April, CDC updated the adult hepatitis B vaccination recommendations to reflect that all adults 19 to 59 years of age should receive the hepatitis B vaccines. Additionally, all adults 60 years and older with risk factors should be vaccinated, and all adults 60 and older, regardless of risk, may be vaccinated. This move away from risk-based recommendations will help reduce health disparities by eliminating the need for patients to disclose potentially stigmatizing risk factors and provide a simplified vaccination decision-making process for providers. Next. In the next few months, CDC anticipates releasing new hepatitis B screening recommendations among adults, which will update current recommendations from risk-based to universal, complementing the universal vaccination approach. The proposed updated recommendations are twofold. First, CDC is recommending that Hep B screening is performed at least once in a lifetime for all adults 18 years and older. Second, CDC is expanding risk-based testing recommendations to include the following populations associated with an increased risk for infection, including 1, persons currently or formerly incarcerated, 2, persons with a history of sexually transmitted infection or multiple sex partners, and 3, persons with a history of hepatitis C infection. These expanded recommendations are intended to address high rates of undiagnosed hepatitis B cases that are missed through a purely risk-based testing approach. Next. On the subject of hepatitis rates, the recently released 2020 viral hepatitis surveillance report represents the ongoing systematic collection, analysis, and interpretation of viral hepatitis-related data. As can be seen in the chart on the left, after a decade of stable rates, the rate of acute hepatitis B abruptly decreased by 32% from 2019 to 2020. It's important to contextualize this drop as it was during the height of the COVID-19 pandemic, when fewer people were seeking non-COVID related health care, fewer people were being tested for hepatitis, and fewer health department staff were tracking hepatitis due to reassignments to COVID-19. The chart on the right shows the rates at which hepatitis B was listed as a cause of death, grouped by age and race ethnicity. The overall U.S. death rate related to hepatitis B was 0.45 deaths per 100,000 population during 2020, representing a 7% increase from 2019. It's important to remember in that same year, the nation experienced an overall increase of 17% in age-adjusted mortality in the context of COVID. In 2020, significant disparities by race persisted with respect to hepatitis B-related deaths. Specifically, rates among Asian and Pacific Islander persons was 9 times the rate of non-Hispanic white persons. Next. The hepatitis B indicators of the National Progress Report provide a picture of the longitudinal progress towards our nation's 2025 viral hepatitis strategic goals. This report indicates that progress has been made with respect to reducing new hepatitis B infections, while gains have been lost with respect to hepatitis B-related mortality. Again, these findings need to be interpreted with caution in the context of COVID. Next. CDC continues to work toward reducing new hepatitis infections and related morbidity and mortality, including among disproportionately affected communities. CDC worked with the Office of Minority Health on a grant that funded up to $500,000 per partner to create model programs to reduce new hepatitis B infections and related deaths via expanded services for priority populations. Work done through this grant included training community health workers in Chicago to serve the Asian and African communities, as well as providing education, screening, and linkage for these same communities in New York City and Washington, Baltimore metropolitan areas. Next. CDC's cooperative agreement titled National Viral Hepatitis Education, Awareness, and Capacity Building for Communities and Providers provides 5 years of funding through a 2-part approach to address hepatitis B. First, organizations funded through Part A lead, maintain, and grow coalitions of diverse public and private organizations providing culturally responsive hepatitis B and/or C education and services to priority populations. This funding supports a variety of activities, including testing, promoting CDC's national education campaigns, and supporting this mini summit. Part B recipients increase the knowledge and skills of healthcare professionals on the management of hepatitis B and hepatitis C via online and continuing education programs. Next. Moving forward, CDC will continue to advance hepatitis B screening and prevention. We are planning to release a comprehensive campaign to promote the adoption of the updated hepatitis B screening and vaccination recommendations. Further, to improve the public's access to our viral hepatitis materials, we will complete the redesign and digital modernization of CDC's viral hepatitis web pages. And we are also working with the Hepatitis B Foundation to disseminate updated and redesigned educational materials for Asian immigrants. CDC's viral hepatitis program will continue to work with partners such as yourselves to promote innovative and holistic approaches to reducing hepatitis B-related disparities among people with or at risk for acquiring hepatitis B. Next. Thank you again for the opportunity to provide opening remarks on the third and final day of this important mini summit.
Thank you so much, Dr. Wester, for those great remarks. And we are very much looking forward to the items coming out of DVH and your DVH's continued support for the coalitions doing the work here. So we have a jam-packed day, and so I'm going to move it right along to Chibo Shinagawa from APCHO, who is going to moderate our next session, which is Moving Beyond the Pandemic. Chibo, take it away.
Thank you so much, Frank, and welcome everyone. Thank you so much, Dr. Wester, for your presentation on Hep B and the disparities in our community. I'm here today to introduce today's session on moving beyond the pandemic. And we're at a place right now where we're living with this pandemic, and how do we coexist with this pandemic? So today's presentation and panel is, in this session, we'll hear from panelists discussing contact tracing and tuberculosis at the start of the pandemic, to navigating a hepatitis screening program in an emergency department during the pandemic, to building a coalition for Hep B advocacy beyond the pandemic. This summit has been so powerful for me personally, as a daughter of an Asian immigrant, and also as someone who's passionate about infectious disease. And in my role, I work as a program manager of infectious diseases at APCHO and support the TB Elimination Alliance. And being a part of this work is powerful, but also I lost my father during the pandemic. And so much of that is what I think speaks to the summit. I'm really moved by a lot of what we've heard about hearing, that this is a love letter to the people on the ground, that we're shifting the narrative, and that healthcare is truly personal, and just the importance and the power of public health in our syndemic programs. And so I'm inspired to introduce today's panel. Our speakers today for today's workshop are Dr. Joseph Berzinski, Director of the TB Control Program at the New York City Department of Health and Mental Hygiene, Ruth Brogdon, a Public Health Program and Grants Manager at RWJ Barnabas Health, and Turner Britton, President of the Utah Center for Civic Improvement. I'll pass it on back to you, Frank.
Hello, I'm Dr. Joe Brzezinski. I'm the director of the Tuberculosis Control Program in New York City. Thank you for inviting me to speak at this conference. I'm going to be talking today a little bit about the epidemiology of tuberculosis in New York City, and talk a little bit about our experience during the COVID pandemic and how we are returning our operations to normal again. So next slide. So first we'll start with some TB epidemiology in New York City. Next slide. So here's our epi curve. Last year we reported 530 cases for a rate of 6 per 100,000. 6 per 100,000 is a pretty low rate globally, but is much higher than most other parts of the United States. In New York City, TB rates were going down consistently until about the late 1980s, when rates started to climb again. The increase in rates at that time was due to the confluence of the HIV epidemic, increased immigration to New York City from countries with high rates of TB, and a dismantling of the public health infrastructure. Our rates in New York City peaked in 1992 after the strong implementation of a new TB control program. Rates quickly declined, but they've largely plateaued over the last decade. Next slide. In New York City, 85% of our cases are in non-US born persons. Last year, the highest reported number of cases were from people who were born in China. Other countries of birth that contributed significantly to our case burden included Ecuador, Bangladesh, India, Philippines, and Mexico. Next slide. So what were the impacts of the COVID-19 epidemic on our TB control program in New York City? Next slide. So TB COVID-19 co-infection, TB patients with COVID-19 are at an elevated risk for complications and should seek immediate medical care. Existing literature suggests that co-infected patients are at a higher risk of severe COVID-19 outcomes. So for patients who may have COVID-19, you should think TB, and patients who are co-infected need prompt medical care. Next slide. This just shows what happened in New York City at the beginning of the epidemic. Many patients with TB were infected with COVID-19 at the beginning of the epidemic in New York City, and there was a very high mortality rate. Many patients were diagnosed at about the same time. While hospitalized for COVID-19, TB was recognized, or while hospitalized for TB, patients were recognized to also have COVID-19. Next slide. Looking at the demographics of patients who had TB and concurrent TB and COVID-19, the ages were similar percentage of male patients, and all other factors were similar. However, next slide. Patients who had concurrent TB and COVID-19 were more likely to have diabetes. Next slide. What we did see was that there was a very high mortality rate in patients with TB and COVID-19 at the beginning of the epidemic. The difference in mortality was most marked in patients over 65 years of age. Next slide. So how did this impact our program? Next slide. Well, at the beginning of the pandemic in New York City, we had 4 TB clinics in the city. We closed 3 of the 4 clinics. We maintained 1 clinic to serve patients that needed immediate care. The rest of our patients, we switched to a telehealth model. We used telehealth using FaceTime and Google Meets to contact patients for their medical visit. And patients who needed medication, we delivered medications to the patients at their homes or through the mail. Our doctors and nurses used telehealth to deliver clinical care services. We also switched to a virtual method for education in medical centers and for outreach events and for case management. We have public health advisors that go into hospitals to interview patients diagnosed with active TB. At the beginning of the COVID epidemic, we switched to a complete virtual model. So we either called patients and did the interview by telephone, or when possible, conducted a telehealth visit for the initial interview and education session with all of our patients diagnosed with TB. And finally, I want to say that this put a tremendous amount of stress on our staff. The staff working in the clinic, of course, never knew if they were going to become infected themselves while working during a time when we did not fully understand the COVID-19 transmission. People who normally worked in the office were working from home. People in our TB staff were given new responsibilities to respond to the COVID outbreak, and ended up working many, many hours. We found that our staff had a lot of burnout, depression. It was a really tough time. So we tried to respond to this with staff wellness efforts. We implemented some times where people could get together, at first virtually, so just so that people could share their experiences, have the availability of mental health counseling, and make sure that people had a chance to take time off. Next slide. So I'm just going to give you a few more updates about tuberculosis control in New York City. This was a study that we were involved in. It's a part of tuberculosis care for us to observe our patients take their medication daily. This is something called DOT. This is a model that's in place globally. We know historically that patients who take treatment for TB would often take their treatment at the beginning of treatment until they started feeling better, and then would quickly drop off. And that is not a very good model in tuberculosis. It can lead to increased drug resistance and failure of therapy. So fortunately, even before the pandemic, we had started a model of electronic DOT using telehealth again instead of in-person DOT. We published a paper last year in the JAMA Network Open showing that electronic DOT was as effective as standard of care in-person DOT. So fortunately, we were able to use this model during the COVID pandemic. Next slide. I also wanted to mention there's some good news in treatment in tuberculosis, published in the New England Journal of Medicine a couple years ago, a new 4-month regimen for the treatment of susceptible TB. We're starting to implement this regimen in our TB clinics in New York City. So the standard of care for most patients with tuberculosis is at least 6 months of treatment. So 4 months is really a big improvement. Next slide. And then finally, for the treatment of multi-drug resistant TB, which historically has required at least 18 months of treatment with very toxic drugs. We recently have had put into use in our clinics what is called the VPAL regimen. This is a combination of drugs including bedaquiline, protominid, and linezolid used to treat multi-drug resistant or extremely drug resistant TB. And we use a 6-month regimen that has been very successful and has been very well tolerated. we've used this now in 15 patients in New York City and have had a lot of success. Next slide. All right, so that's all I wanted to say. I'd be glad to take any questions about our program for TB control, and thank you.
Good afternoon, everyone. Thank you so much for this ability to meet with you today to speak about our experiences and learnings in the hepatitis B space with regards to screenings, linkage to care, and community outreach at our primary care practice here at Cooperman-Barnabas Medical Center. Here at Cooperman-Barnabas Medical Center, I work at the Center for Asian Health, which is a primary care practice that was launched in 2013, and it was launched to reach the growing Asian population of New Jersey with bilingual providers, staff, and navigators. We provide culturally sensitive and appropriate care. Our disease focus is both diabetes and cancer prevention with an emphasis on hepatitis B and screenings. We know that we want to work towards hepatitis B elimination by the year 2030, and we do have the tools to do that through prevention strategies, diagnostics, vaccines, and treatments. We also realize there are many people living out there with hepatitis B who have not yet been diagnosed. So we need to be innovative in our approaches in our goal to elimination. And one of them has been scaling up testing and care delivery with our hospital-based screening and linkage to care program. Also, in addition to our clinical services here at Center for Asian Health, we do conduct community-based research and outreach, which I will be discussing. In this presentation, I'm going to be speaking specifically about the challenges that we have faced with our hospital-based screening and linkage to care program, our primary care services here at the Center for Asian Health, and also community outreach. So this is the overall flow of our hospital-based screening and linkage to care program, which really falls under three buckets of areas. The actual screening that's done in the emergency department or inpatient. When a patient is found to be positive, a patient navigator works with that patient. And then the patient navigator links that patient to our internal medicine practice. So when a patient is screened in our hospital program, in real time, the patient navigator does receive the positive lab result. The navigator then reaches out to the patient and educates the patient and provides them linkage to care to our clinic in Florham Park Multi-Specialty. The navigator then works with the primary care physician to follow the patient at the clinic, where the patient is seen by an internist and they determine a care plan. They work with a care team, which involves a pharmacist, who will then determine treatment eligibility, approvals for medication, and delivery of meds. So these are graphs of our screening trends for both hepatitis B and we also do hepatitis C from the beginning of our program. And you can see here, right here around March 2020, you see the dip where we were screening close to 800, 700 individuals a month in terms of hepatitis C, and in terms of hepatitis B, about 200. But then we have this dip in April over here, both in B and C. And this is in line with the decrease that we saw in the emergency department in terms of our volume. And we estimate that that volume decreased by about 50%. So this definitely affected our screening program at the hospital. It did dip down, but then we also saw a pickup in May, and since then our testing has mostly stabilized. So the issues that came about with our linkage to care from the screening program was that once the navigator did identify, once a patient was identified as positive and then brought to the attention of the navigator then began the process of trying to link that patient to care. But we did find that there were transportation issues with getting the patient to come to our primary care practice. There were definitely issues of fear, of hesitancy, of coming into the clinic because there was, the isolation protocols that were in place and practices that were in place. I put fear up there because there is also this intersection of what was going on at the time with the anti-Asian hate crime. So a lot of our patients at Center for Asian Health did not want to or didn't feel comfortable to come out to the practice. There was also patients having issues with access to their medication. In the past, they would just go to their retail pharmacy, pick up their meds, and that was not an issue. But again, during COVID, not traveling, trying to maintain social distancing, that became an issue. And then there were, of course, also competing diagnoses. So the competing diagnoses could be those diagnoses of higher acuity or just simply COVID. So those patients were not, taking care of their hepatitis diagnosis. So in response to that, telehealth came into place. We know we've all heard so much about telehealth, but some of the interesting and kind of positive, fallouts of telehealth as well is that sometimes with telehealth, we would have patients that were being seen and have family members there. And so at times the doctor would be talking about hepatitis screening and care and maintenance, and then a family member would be there, and then the doctor could encourage the family member to also get tested. So we kind of got, 2 for 1 in that case. And then that family member would also then get tested and then follow up with their physician. We also then put into our protocol having patients use mail order pharmacies because patients were having difficulty getting their medications. And the solution really was just to call the patients to see if they wanted to have their refills delivered at home and get a full 90-day supply. And that was something that they really opted for. Also, our navigators pivoted in terms of just reaching out and following up on patients and making sure that they were okay with their meds. They were maintaining their hepatitis care. This also just, then highlighted how important it was to have the correct contact information so that we could stay in touch with patients who otherwise were not coming into the clinic and seeing them. So this just caused us to just revisit our registrar at the hospital emergency department and inpatient to emphasize the importance of the correct contact information. So as the hospital screening program continued at Cooperman-Barnabas Medical Center in the ED and inpatient, we did see that if diagnosed with COVID-19 and we had a Hep B positive patient, the recommendation was not to initiate treatment. And if they were a non-COVID patient, but they were newly diagnosed with hepatitis B, we also saw that a lot of the patients preferred to wait for further evaluation and maintenance and treatment because, again, they didn't want to come into the clinic. For our established patients, we did continue to see them virtually on a regular schedule. Unfortunately, a few patients did not want to come in to do the blood work, so that caused some issues there. Our office visit numbers really did drop, and then our staff had to pivot to really call in and call patients to check in on them. We particularly saw this with our elderly patients and those patients who had transportation and health issues. Our ambulatory care pharmacist was able to provide one-on-one consultation via telehealth, so that was able to continue. If a patient was, again, as I mentioned, on medications, we would encourage them to use like drive-through pickup at the retail pharmacies. But if that was not available, again, to switch to home delivery. We talked to patients about their blood work and different imaging studies that needed to be done. And, if it could be delayed, it was not urgent, as some of them, again, did not want to go out and do that. Taking just a wider lens, looking back, some of the other effects of COVID were that from the hospital, bird's eye view, looking at it, the hospital had acquired additional molecular diagnostic machines to perform COVID testing. And this worked out well because these machines were also compatible for performing hepatitis B and C viral loads. So by performing it in-house, this just reduced the turnaround time in getting results. Now our system has 2 hospitals with larger labs, and these larger labs serve our other sister hospitals in the system to do this molecular testing. So again, a shorter turnaround time and getting the results quicker to our patients. We are continuing telehealth. It is now an established and instituted in our system. It really does help accommodate those patients with schedule barriers as well as transportation barriers. And iPads which were ubiquitous during COVID, as nurses and the floors used this to have patients get in touch with their patients. What we learned from the iPad is that there was a very effective iPad translator to help with language barriers. And this was much more effective than the audio-only language line because there was a visual of the interpreter. And this was very applicable to our patients here at the Center for Asian Health. So in terms of community outreach, I'm sure you've heard this time and time again. The greatest restriction was that we had to discontinue in-person activities. And that most definitely was the case. And we had to then take on doing more virtual education opportunities, such as educational webinars. But what was key to this was that we needed to make sure that those webinars were topics that were relevant to the moment. So we were able to offer a webinar on vision care, specifically eye care for children, because there was a concern of children's eyesight declining due to too much screen time. There was also obviously webinars on vaccines and also a webinar on psychological problems that were caused by the social isolation from COVID-19. And I sneaked in a picture in there in the corner that we actually snuck in there a screening in July of 2020, was our only in-person screening, not well attended, and I think it had to do with the heat, but also some hesitation for coming in person. In terms of community outreach, not only did we go out to provide services, but we also went out into the community to get an understanding of what the community needs were in terms of services that we could provide in the future. In fall of 2019, we had just implemented a health-related social needs tool to determine the access for cancer screening and primary care for our patients. This was a survey that was done through the iPad or through paper when a patient came into our office. But that became a challenge when we started having declining office visits. So we had to pivot in April of 2020 and modify the protocol to be we had to modify the protocol to recruit patients by virtually by sending out emails and patient portal messages. We still didn't have a lot of traffic in the office, so then we had to modify the protocol in September of 2020 to recruit people by allowing them to do the survey at home and to mail it back in person. From this study, we did find that there were a lot of social issues for our Asian American population in terms of dealing with interpersonal violence and food insecurity, and also just having a low neighborhood perception and belonging. But this is interesting because these findings came at an intersection in time with the acts of violence and racism against the AAPI population. So this was all came relevant for us in understanding the social structures that affected our population in accessing their health care, and particularly their hepatitis B care. And I just want to bring up this executive summary from the Asian American Psychological Association that reported close to 44% of the population reported a decline in self-rated health since the pandemic, whether it was comorbid physical or mental conditions. They became the most vulnerable to a health decline. And also 41% of the respondents did delay in getting medical care. So this is all very relevant to hepatitis B care in our clinic. So moving forward, what did we learn and what are we going to do? So with our screening and linkage to care programs, we continue our automated program at the hospital, but in terms of our community programs, we're really in like a catch-up screening mode right now. So through opportunities, through mini grants, for screenings, we're now going back out into the community. We have had some uptake with that and some interest with that, and also an opportunity to provide vaccinations. Through our hospital screening program, we have a very large database, and by collecting this data, we can identify gaps in high-risk groups. Our remote navigation continues not only through the telehealth, offering the telehealth, but also the calls. We have a navigation system that is centrally located in Livingston, but not only serves our hospital, but many other sister hospitals and other hospitals that we're going to be expanding to. Our navigators are quite effective, whether it's through calls or even text messages, to get a patient to respond and to get linked to care. We are fine-tuning our service provision in our primary care services in terms of, instituting telehealth for, now and into the future, mail order pharmacies as part of our protocol, and just increasing the comfort level for our patients as they come in, ensuring them that it's not only a COVID-safe facility here at the clinic, but also the downstream services that they will need in terms of laboratory work or imaging and pharmacies as well. And in terms of community outreach, we are re-engaging. We're re-engaging with a hybrid concept, realizing that as we go out physically in person, we also need to keep those opportunities available in terms of virtual learning and webinars and education outreach. We are also emphasizing education and public health messaging on the importance of seeking care in terms of hepatitis, hepatitis care maintenance, and also vaccination. I want to thank you very much again for this opportunity, and I do look forward to your questions.
Good morning. My name is Turner Bitton. I am the current chair of the Utah Hepatitis Coalition. I helped found the Hepatitis Coalition in 2020 and 2021. It took us 2 years to get things up and going, and we were very fortunate to get a grant from the Utah Department of Health that made our work possible. And today, I'm hoping to share some of the lessons learned that we have learned over the course of the last couple of years. Starting a coalition in the middle of a pandemic was not what we expected to be doing, but nonetheless, we found success and been able to get going. So during today's conversation, I will not be presenting on slides. I'm a pretty informal person and prefer more conversational styles. So what I'm hoping to do today is first, I'm going to outline the challenges that we encountered starting a coalition. And I should note that some of these challenges are a little bit more broad than just our coalition, but I think they're applicable to the work of combating viral hepatitis throughout the country. So I'll start with our challenges, and then I'll move on to lessons learned. And then last, I'll focus on some items for moving forward and addressing some of the challenges that we've talked about today. So as I noted, not all of these are specific to the work of combating viral hepatitis. Some of them are just lessons learned in, I've got now about 15 years of community organizing experience. I work on a variety of different causes and issues, and some of these lessons are from there. So I'd like to start first with the challenges. And I think all of us would agree that after 2 years of rushing to recreate our world in a digital format, that rush to move everything to a digital platform has resulted in some unintended consequences. If you're like me, you like the fact that we can now meet, and if we're having a meeting to discuss things, to do some stuff, to organize and to move forward, I personally greatly prefer meeting digitally for those things. But what the rush to digital platforms has done, in my experience, is that it's made our work feel more transactional and less relational. I can count, every time that I meet someone for the first time after having met them online, oftentimes there's this awkward moment where it's like, well, I recognize you. Do you recognize me? We've met online. I didn't know you were so tall. I didn't know you weren't tall. They didn't know I wasn't tall, stuff like that. So getting to know one another and really developing those relationships, seeing each other as humans, not as little squares and little boxes on a screen. It's taking some time to get used to that first impression being met online and then subsequently meeting people in person. I mentioned that it's made our relationships more transactional. And in my experience, I don't like the fact that we often are meeting people to accomplish things. I know that kind of flies in the face of what I just said about liking to meet online, but the project manager in me that loves productivity loves having a short meeting, and I consider it a success when we're able to end early and give people back more time in their day. But what that results in oftentimes is this sense that we're only meeting because we need something from one another, and we're not meeting to connect, we're not meeting to develop relationships. And one of my core tenets in organizing is relationship development. We don't often agree, we don't often share the same opinions, but certainly we can agree that we're all doing the work, that as long as we're engaging in good faith, even when we disagree, that we're doing the work. And so the second issue that I think that we've faced that is a challenge of rushing to go digital is the oversaturation of digital platforms. Myself, back in May, made the decision to leave all social media. So I downloaded all of my data archives, all my photos, 15 years of social media posts, and made the decision to delete permanently all of my social media. So for the first time since I was a teenager, I'm no longer on any of the social media platforms, Facebook, Instagram, LinkedIn, none of it. And it's been a pretty liberating experience. I had pretty much convinced myself that social media was essential to the work that we do and trying to build networks and connecting with folks. And after just over 5 months of not being on social media, I can tell you that none of that is true. And what I've actually found and what I learned during that process is that we spend a significant amount of time putting content out on social media that nobody reads and nobody sees, because algorithms determine what folks are seeing. And that oversaturation, the desire to educate the public, to put information out on social media, it might be counterintuitive, but oftentimes I think we're wasting our time. We've rushed to launch things on social media and other digital platforms, and oftentimes, speaking with folks in our meetings, they didn't see what we posted anyway, so it was all a waste of time. And so some of the lessons that I've learned over the last couple of years, especially organizing as things were digital, was that people have plenty of stuff. I don't know about you all, but as the pandemic got fully underway, I started to receive bumper stickers and lots of swag in the mail from the organizations that I follow, because I think folks felt that it was hard to generate relationships with our supporters and our clients without providing things. But over the last couple of years of organizing, one of the key lessons that's come out for me is that people can buy what they want, and they generally will. What they can't often buy are a sense of community and experiences that shape their lives. And so as COVID got underway, as we moved to digital platforms, one of the things that I have actively tried to do is to reinforce this desire for experiences and connection. And as an example of that, looking at all of my events that I host and that I organize, I think it's very important to develop a relationship and a profile of the folks you're trying to have at the meeting or at the event, and really developing an understanding and really being intentional about why you're meeting in the first place. And I'll come back to this point in a moment. But again, people can buy what they want, but they can't buy experiences that connect them to a broader story, to a bigger narrative, to that sense of altruism that each of us has, that we're connected to things that are bigger than ourselves. So an example of those, and this is not the Hepatitis Coalition, although we're looking at expanding into this. For the last several years, I have organized an event with some others called Beer in a Shot. Basically, we've partnered with local breweries to offer the seasonal flu shot at their brewery establishments. And what we do is we generally provide a $3 or a $5 gift card to that brewery for a free beer. So we buy them a beer in exchange for them getting their flu shot. What we've done is tried to target the young invincibles and the folks that generally have lower uptake of flu vaccinations. We also, during the height of COVID, did drive-through COVID and flu vaccination clinics, where folks could come through with their family in the minivan, in their car, drive through, get their flu shots, get their COVID vaccines. And then at the end, we actually had a food bank. We had vision tests for kids since they weren't in school. They were not getting their vision tests. We were able to do all of this in a drive-through setting. And what we found, we also handed out cupcakes and snacks and warm drinks like coffee and hot chocolate during these events. But what we found is just the experience of getting your family in the car and going to do something different that you don't normally do, like a drive-through flu shot clinic, became a family experience. And we got a lot of positive feedback and messages from folks that they really liked the style of the event. So the lesson from all of that is experiences over stuff. And second, that there's no replacement for organizing, good old-fashioned one-on-one outreach to another human being. And so I mentioned I'm not on social media. And so what we've done is really organized around the three kind of core ways that folks communicate in our modern world. And nothing can replace a good old-fashioned phone call, a text message, or emails. As we've shifted more online, social media has become far more, I'm going to say, polluted with different messages, and getting folks to be able to first even see those messages, and then second, be able to take action has been greatly minimized by just the sheer amount of content that's created on social media. So as I look forward to the future of our work, I have a few recommendations for organizations that are looking to organize in an increasingly digital world. And the first one is, as you're planning events, as you're planning meetings and gatherings, don't forget that the reason that people are there is to connect with one another. The best programs in the world The best events in the world, the best things that you get to participate in are the ones that nourish you as a person. And living in a state that I think could be described as fairly conservative, that traditionally might be a bit hostile or unfamiliar with things like harm reduction and public health interventions as opposed to criminal justice interventions. Being in a state like that means that oftentimes as an individual, I can feel disconnected from the broader social media or social movements that I connect with as an individual and that I identify with. And so as I plan events and as I think about the future of events, it is so important that when you're organizing an event, rather than just getting bogged down in the details of where is someone sitting, what are they going to do, to also be thinking about how it will make them feel about themselves. And I really think as we organize events, whether they're online or in person, we have to focus on the broader narrative. What does a person who's attending this event take back? How does it inform their identity? How does it inform their sense of self? And how does the event help advance that? So some of those suggestions are to cultivate connection. I think we often plan events to maximize the amount of productivity. We go from one class to the next class or one subject to the next subject, when in reality, our brains need time to take a break, and we need time as individuals to really process with others what we have just learned. So as we're planning events, whether it's a monthly coalition event, whether it's a quarterly big event, whether it's a signature fundraiser, the most important thing is to cultivate connection and that sense of community. Build time into the agenda where there's no structure, where there's an opportunity for people to just meet on the sidelines. The biggest thing that we've all lost by only holding digital events is the opportunity to connect with one another off screen, on the sidelines. And certainly for me, when I look back at the best conferences and the best events I've been to, they've been places where I've met new friends, connected with people in bigger movements than myself, and I've had a chance to connect with the things that really energize me. And connection and community are the things that I think energize all of us, especially those of us that can feel like we're on a little island in the middle of a big area like Utah. Oftentimes living in Salt Lake City and Salt Lake County, I live in an area that is very receptive to my ideas, but the state broadly might not be. And so those opportunities to connect become increasingly more important. I think the other thing that I'm taking away from the last couple of years is we can meet less often and maintain connection. So I'm a big fan. You may have heard of email inbox zero. I'm moving toward calendar zero, where I try to, during large periods of time, today is a good example. I'm going to be spending most of my time working on projects as opposed to sitting in meetings. And it gives me a chance, as I mentioned, to really process all the concepts, all the discussion, all the conversation that is happening in the many meetings that I have. And so by reducing the overall number of meetings, but really promoting connection, we can improve our productivity and develop stronger ties that help us organize better. And then the last thing, there is so much noise out there and so many demands on everyone's attention that I am a big fan of personal invitations. Instead of spending all my time creating an event on Facebook, inviting everyone on my friends list, developing social media content that only a small population is going to actually consume, I like to spend my time making personal calls, sending personal emails, and sending text messages to individuals to invite them personally to meetings and events that I'm hosting. So rather than trying to go for quantity, I'm trying to really reinforce quality. And what I've found is that it helps not only develop relationships, but it also makes the work easier, because when we do have disagreements or when we have different ideas, if we have relationships and we feel that we were personally invited into the work, we feel more confident sharing those lessons, sharing that information, and pushing back and challenging one another when that is necessary. So if I can summarize all of this into kind of one idea, it's that as organizations, we are social movements fundamentally, and we're about relationships. And when we center relationships over all of the other things, all the other demands of our time, like social media and mass emails, when we center relationships and connection, we can build organizations and build movements that are resilient to things like COVID. For me, the things that got me through the COVID era were not the quick transition to digital events. It wasn't signing in to Zoom. It was the fact that I had established relationships, that I could develop friendships that I could draw on, and that I had people that I could rely on to help me process everything that's happening. And I think for myself especially, the last couple of years have been defined by reflection and really thinking about the ways that I'm connecting to the work that I do. And for me, fighting back against burnout means connecting with other people and feeling like I'm part of something that is bigger than myself. So if I could boil all of this down, it's don't meet to meet. Don't just have a meeting to have a meeting. It's okay if there's nothing that needs to be on the agenda to cancel your board meeting and instead have a lunch meeting where you just get together informally and have a conversation, share space together, get to know one another. And then I would really encourage you, as you think about your calendar, when I look at mine, it's often full of meetings. And I often wonder, could this meeting have been an email? Could this meeting have been a sidebar conversation after staff meeting? Could this meeting be something other than a meeting? And as I found that, and as I've really looked at the intention behind the many meetings I have, oftentimes I think we schedule meetings just for the sake of meetings so that we feel that we've connected with other people. But what is often missing is that actual connection that underlies the work that we're all doing. So if there's one thing that I can recommend moving forward, it's connecting, it's reinforcing that sense of community, and it's practicing intention, not only with your time, but with the time of all the folks that we're all constantly organizing with. And as we come out of the COVID years and look forward to the next pandemic or look forward to the next challenge, we have to center relationships and community in order to mitigate the worst impacts of public health crises. So as individuals, let's today start with the intention of connecting through this device, through the internet, but making plans to connect more fully, more broadly, and more intentionally together when we're able to be in person. Thank you.
Thank you so much, Turner and Dr. Brzezinski and Ruth. And if I could just have Turner, Dr. Brzezinski, and Ruth spotlighted together here with me, we can take some time for some Q&A. I just really enjoyed all of your presentations today, and I think they were different, but all interconnected in different ways. And Turner, your presentation just really, I feel like, excited me to continue this dialogue and to really think intentionally about how we're going to come together for this summit. And I just really appreciated that. I'm going, and Dr. Brzezinski, thank you so much for sharing more about, what's going on in the epidemiology of TB in New York City, and also just what your staff are facing with the stress of the COVID-19 transmission and a lot of that burnout and how you had to pivot. I was quite moved to hear about the practices that you're doing in telehealth and also your treatment in TB. Ruth, it's really crucial and important to hear about the perspectives of what you're doing at Center for Asian Health. And I very much appreciate, as an Asian American woman, also to hear about, just the ways that you found intention to our communities and how you were more inclusive to address anti-Asian hate, but also looking at some of the ways that you utilize telehealth and building in your screening programs to really implement a safe space for our communities. So I'm delighted to have you all here. I'm gonna address a few questions that we have from the chat. And first of all, I just wanna also acknowledge some of the comments that folks have made. And so first, I just wanna say that Wendy shared, sadly, there was a lot of rampant anti-Asian hate crimes in Vancouver, and she had faced it personally as well during the pandemic. And thank you for sharing that, Wendy, and for really just, sharing your story. Sue Wayne shared a hospital video translator program, and Elena shared that she agrees with the lived experiences and that all of these lived experiences can connect us to bigger things other than ourselves. So we have a question from the chat from Abby, and Abby's question is, how do you find a new connection to phone, text, and email? And I think this might be related more to like organizing, sort of how do you better cultivate these connections and utilize these ways of organizing and bringing intention to our meetings, to our summit. So I'd first like to ask Turner, but I also want to bring it to Dr. Brzezinski and Ruth too. Working with your patients, working with your staff, how do you cultivate, community, and how do you cultivate these ways of just interacting with one another during this pandemic and beyond this pandemic?
Yeah. So my first piece of advice, if you're having kind of public meetings, looking for new connections, that you're tracking attendance at your meetings. And then when you meet, if it's with a board or with with colleagues, that after each meeting, you're really reflecting on who was in the meeting, who wasn't in the meeting, and kind of engaging in network organizing. So oftentimes what we'll do, we'll take the attendees list from one of our meetings or events, and then we'll sit down and we'll think as a group, who do we think should have been in the room that wasn't in the room? And I would say to start with your immediate network, because that's where you have the strongest social capital to then make direct asks to bring people into the next meeting. I will admit that the one benefit of social media is that it makes it easier to find folks, to connect with folks that you maybe have never met before. But in general, what I found is that by focusing on existing social networks where you've got existing connections, you can start to identify those gaps and make those connections and really embrace the role of having the folks that are involved in your organization as ambassadors. Whether it's the receptionist at the front desk all the way up to the CEO, there's an opportunity for each person to play an ambassador role and bring new people into the work.
Thank you, Turner. Ruth?
Yeah, Chiba, I'd just like to add something that we're learning as we're getting back out into the community and re-engaging. And I had mentioned that we're taking on a hybrid model as we go out, and our in-person events may be a little bit more smaller than what we had in the past. What we've learned, and this actually came up in a conversation today, is for those who do attend, and this goes to what Turner had shared, is seeing who attended, reaching out to who attended, and if they, they provide feedback that the webinar was great or the focus group was great, letting them be our ambassadors for promoting the next program. So, they're our greatest publicists, so to say, and they can help, spread our message, get people back into the community engagement, or the community events, or whether it's our clinic. So, capitalizing on who we reach out to already and using them, and then they also feel like they have a vested interest in what we're doing.
Thank you so much, Ruth. And I actually see a question here from Richard. Has your program been only focused on ER, HBV, and HCV testing? So just kind of looking more at, with its success, have you done any outpatient or regular primary care testing, in addition to kind of exploring just the work that you're doing in hybrid work too?
Sure. So the hospital screening program that I discussed is only in the hospital, at the ED and inpatient. It's an automated screening program, which is set up in our EMR, but in our clinic, we do testing. Our providers do offer that as part of their well check and annual visits, but it's not part of a automated program as part of the ER. We are looking and working towards that as our system is moving to a new EMR and making that part of a routine systemized part of our outpatient and primary care practice.
Thank you. Dr. Brzezinski, we have a question from Dr. Wen. Moving forward, are you planning to continue with mostly televisit, both, or do you feel that resuming in-person care for TB patients is important?
Well, I'll answer that by saying, thanks for the question. Yeah, we have resumed in-person visits pretty much at full capacity. And I think there's something very important about having the ability to see patients in person in clinic, the relationships we generate that way. And TB, for people who are not real familiar, there are many visits to the clinic. There's the initial visit and all the testing, and then every 2-week visit or the every month visit. And you really get to know your patients really well. I think it's very important establishing those relationships. We actually have several people working in our clinics now as doctors and nurses who were former patients because they felt that they valued that experience and they wanted to continue with us. We still do have a telehealth option for certain visits, particularly in the later follow-up stages when we know the patients are very stable. We need to check in with them once a month maybe, but if they're otherwise young and healthy, we feel pretty comfortable with telehealth. If it's really inconvenient for somebody to make it to the clinic, we'll do that as an option, but it's not our preferred option. And also with the interviews of the patients, we encourage our public health advisors to do an in-person interview if at all possible. Kind of the telehealth is the backup if for some reason we can't do the in-person. I love that just connect. That's a great statement. So thank you for that talk.
Yeah. Thank you so much, Dr. Brzezinski, and just kind of explaining more about, telehealth and kind of the aims for that. We have another question for Turner, and I know we're kind of jumping around, but these are all interconnected, all of these issues as we talk about the pandemic. And, I'd like to, I think this is a question, with so many issues competing for time and attention, how can we embed viral hepatitis into the policy dialogue and elevate it as something we collectively care about and take action on? And, I actually would give this question to Turner, but also for anyone else who wants to also address TB and viral hepatitis. So this is all open for all three of you, thinking about, how we can elevate this care and action.
Yeah, from my perspective, the best way to elevate any issue is to first build a very solid base. I think a lot of times, and I think what will come clear is kind of my personal distaste and distrust, I guess, of social media as an effective form of organizing. But I think we often spend time on first trying to reach out to the masses. We want to just reach out and reach thousands of people very, very quick. As a society, I'd say we've kind of become obsessed with virality and the sense that we need to be on the front page of the paper every day in order to really engage people. But I would push back on that and say that the first kind of foundational step is to build a really, really strong foundation and a base of support. And what I have found in working with our legislature, and I recognize the dynamics are not going to translate everywhere, but when you have a small group that is very organized and very committed to the work, you can then build organizations that are capable then of going out and reaching the masses, if you will. So as an example, with the organizations that I work with, I might not have a preference for social media, but what I try to do is I'm organizing the core group rather than try myself as someone who's not very good at social media in the first place. Rather than me try to do that, I am looking for the skill sets that I want to have around the table, and having someone with a background in social media or with media relations, with that type of thing, with engaging with journalists. What I do is kind of a systems analysis where I identify the strengths that we need around the table in order to take advantage of those skill sets to then in the future build out those campaigns. And so as an example, with the Utah Hepatitis Coalition, we have been for the last couple of months working to recruit a webmaster. We've just found that person. This is someone who loves social media, loves connecting with people in digital spaces. And so we've built the foundation now that we then have the ability to go out and do the kind of digital organizing. I do think digital organizing is important, but I don't think we should center it as the main form of organizing that we do in our work.
Thank you, Turner. Ruth.
I would just say, after the pandemic, just the term infectious disease and vaccines just became, common terms now for everyone. And building off of that, especially working in the primary care areas, we talk about wellness and vaccines, and we're talking about flu vaccines at this time of the year. We're talking about getting your bivalent booster at this time of the year. There's an opportunity there to then also add in about the importance of hepatitis B and consequentially, vaccination. So if, working in whatever space that you are, building on what has happened post-pandemic and what is really like on the ear of everyone. And again, like, vaccines was a bad thing at one point, not a bad thing. Now it's being talked about, period. So I think there's an opportunity to, to increase that in terms of hepatitis B now.
Thank you, Ruth and Turner. Dr. Brzezinski, any final comments or anything else you'd like to share?
Not really. I think we rely too on established social networks. We have a TB coalition in New York City. So we have partners throughout the city that we've worked with and know. And so when we get together, I think we're able to work effectively and rely on our partners to spread our message. We've started going out into the community to do TB rounds or brand rounds in person at hospitals. And that direct connection with the providers in the hospital, I think, is really, really key. They remember the message, and then they feel free to reach out and contact us when they need to.
Well, thank you very much, Dr. Brzezinski, Ruth, Turner. Thank you for showing up and for really being an active voice in our communities and doing this work. And yes, so right now we are actually going to transition. I want to make sure that you all have